My name is Stephen Slough. I'm the Chief Information Officer for Dorset CCG, for Dorset County Hospital and for Dorset Healthcare, which is the Community and Mental Health Trust in Dorset. And in my spare time, I lead the portfolio that we have in our ICS for digital transformation. So I'm kept quite busy. And today, I want to just give you a quick overview of the way we've approached innovation in Dorset, and also then give you an overview of some of the work we're doing with data, kind of harking back to the start of the conversation this morning. So just a very quick overview. Appreciate that I'm from outside of the county. So this is what Dorset broadly looks like. It's very squiggly. So we've got 18 primary care networks in the new world, about 81 GP practices now. 3 years ago when I joined the NHS, we had 104, I think. So it gives you an idea about kind of the impact that's been going on. We also had a whole bunch of councils, and we've now only got 2. And our population's gone up by about 30,000 in 3 years. Must be something in the water. So we've got 3 acute hospitals, 1 community mental health trust. We consider SWAST as a partner in everything that we do. We've got our 2 councils, and obviously Public Health England are involved in what we're up to as well. So there's quite a diverse and yet quite small and beautifully formed landscape that we have to work in. So we set up, the same as every other STP footprint, our digital roadmap back in 2016, which broadly had these programs in it. We added in research in the kind of recasting of this digital strategy this year. So it was always an ambition, it was always something we're going to move to, but we've formally put it in there now. And you'll be pleased to see, Andy, that we've got culture and leadership in there as well, which is definitely very, very, very important. But this area here, looking at innovation and how we include the population and involve them in their treatment journey, was in there from the beginning. This other one, the intelligent working piece, how we were going to deal with data, was also in there from the beginning. And it was interesting for me when I started in the NHS that there was actually a lot of pushback about doing more with data. Accepting that, as a trust and as an organisation, your data is how you get paid. So you don't want to be giving up your data, because if people can start to see what it might look like before clinical coding have got their hands on it, that's why wearing multiple hats is really cool in my job. It kind of opens up some of the things you might not want the commissioner to see. We're quite lucky now having a control total, because that kind of doesn't really matter. You just get a lump of money and you have to deliver the service. So that competition element, if you like, that was introduced a while ago, has now gone away. So I was told that data wasn't important. We didn't need to look at data, and very definitely wasn't something we should be focused on. Ignored what people said, focused on it anyway, and I'll be able to show in a little minute what we've been able to do with our efforts in that space. And I think there is something in that. A lot of the time we do fill in forms, we do go through processes, we do abdicate responsibility by giving it up to a committee and letting somebody else decide. Well, we haven't done that on everything, we have to do it on some things. Don't want to break the law, but we just got on and done some things. And if you get into trouble for it afterwards, I'd much rather than have to apologise for that than waste years not moving on something because committees can't make a decision. So, right from the outset, we realised that we'd be looking at kind of 2 areas. We'd be driving efficiency with what we could do with data and how we could use data smarter, pulling all of our applications together so we had at least interoperable data flowing between all of the organisations, and the creation of our Dorset Care Record, which is a single digital record in the county. All those things will help us drive efficiency, and we're now working on a slightly broader care record together with our colleagues in Hampshire and Isle of Wight, because despite being in the southwest, we've still got our AHSN is Wessex. I think our LEP is as well, and all sort of weird things are all going the wrong way. But that was all looking at efficiency. Everything else then, how we do this, is all going to be linked to culture, and a bit like I think you mentioned this morning with the digital champions in the local economy. Our local authorities were already really pushing on that and had a number, and we're now supporting them as much as we can as well. Because if you think about the IT teams that we've all got, about 300 IT staff in Dorset, they're all digital champions, so they can all help everybody if they have questions. Interestingly, we also have quite an ageing population in Dorset as well. Interestingly, you find that more and more it's the older generations that actually understand it quite well and are actually quite keen and quite enthused to want to use technology, and it might be some of the younger generations that are less engaged, which is quite interesting, and you wouldn't necessarily think that was the case. So, Empowered Self-Care was one of those 6 core programs, and this is really how we started to get the public more engaged with looking after themselves. So rather than run their bodies and their health into the ground and then rock up at the emergency department or the GP or the community setting and say, fix me, I'm broken, we want people to take more care over their health. And we've started to look at ways that we can put apps out there, that we can encourage people to use more digital technology to monitor their health and monitor their treatment as we've progressed with our programme. I thought this was quite interesting. I'm not going to spend too much time on it. So the Topple report said within 20 years, 90% of all jobs in the NHS will require some element of digital skills. Are there many that don't already? Was what I thought when I read that. I mean, most people have to at least log on to something. So I thought that was a bit strange. I don't know if anybody knows why it would be in 20 years. But anyway. So if we look at what we've achieved with Empowered Self-Care, I know we spoke this morning about remote consultations. In Dorset, we're using Attend Anywhere. We're using that heavily in Dorset Healthcare. As I was saying to Nick at lunch, that's actually taken off faster than Skype. And that does almost exactly what the guy from Microsoft said his product did, but you don't need Teams, which can cost quite a bit. This is not free, but it was developed in Australia. It's used extensively there. It's used extensively in Scotland with the NHS there. We've got the same problem, lots of geographic distance, lots of mobile nurses, and lots of people needing to travel to a care centre. So rather than get them to travel, if you can treat them over a link, do that. As I say, that took off faster than Skype in Dorset Healthcare, and actually our use of it now, bearing in mind we're doing it kind of as a pilot and a bit of a trial and see how it works, has outstripped the usage in Scotland. So it's definitely working. I'm planning to put that into primary care, and we're looking at it for our outpatient consultation programme for the acute setting as well. Acute hospitals, I think, all acute hospitals nationally have been given 20 waiting rooms of this, paid for by NHS, for at least the next 12 months. So if you are thinking of doing something in this space and want to try something for free, it's at least worth a look, particularly if somebody else is going to pay. We mentioned as well the piece of tech which you can hold a phone up in front of your face and it will take some vital observations of you. Lifelight is what that's called, from a company by Zim. We've been working with Zim and the AHSN on that product now for a few years to support them and hopefully get it to a point where we can start to benefit from using it as well. So we've written letters of support, we've supported them with trials and so on. It's really very cool, and you don't need to have a blood pressure cuff that has to be recalibrated. It's all on, can all be used on your phone. So well worth a look at as well. My COPD was mentioned, so we've worked with the company behind that. We helped to develop that because we did buy the licenses and got involved with them very early on. So we've actually got a lot of evidence to show that that's actually very beneficial if you can get people to keep using it. So we've done more and more and more with apps. Weightless is another one that we wanted to roll out in the summer because there were lots of forms to fill in. It took a bit longer, and we rolled it out in time for winter. But if you're in Dorset, download this app. If you one of your children or your friends stubs their toe on Weymouth Beach, rather than go all the way to Dorset County Hospital, which is a bit of a trek up over the top and into Dorchester, where you might sit in the emergency department for a while, there's a minor injuries unit just behind the beach. Weightless will tell you where they all are and what you can be treated for when you get there, how many people are waiting, how long you'll wait, and how long it'll take to get there by foot, by train, by bus, and so on, or by car. So we have a bid in with our system at the minute to sign up to a company called Orca. Has anybody heard of Orca? An organisation called Orca? So they look at all of these sorts of apps and to a degree regulate them. They check that they will do what they say they will do. And they will measure how many people have used them and whether they've actually worked. So if you're worried about spending a lot of time trying to work out if these things are beneficial, they've done that for you. You have to pay. I think it's about 60 grand a year. We're going to do it for a year and see what it's like. So our GPs and our clinicians can prescribe something from an approved list that has proven to work on the area they have prescribed it for. If it works, we'll renew it again. If it doesn't, we won't. Which is a bit of that kind of try it. If it works, keep going. So, moving on to the intelligent working bit, which is the other piece Heath wanted me to talk about. So, it has been in our digital strategy since we set it in 2016, as I said. And what I wanted the guys to develop at that time was to get all of these different disparate data sets all together into one place to allow us to analyse them. Are we treating people in the east the same as we're treating them in the west, as the north, as the south? Is the same treatment being delivered by a GP in one practice being delivered in the same way to the same benefit in another? Are the medications working properly? And the sorts of questions that we'd all want to know the answers to. I wanted somewhere that we could do that. And they've done it, really. Sounds a bit anticlimactic, that, but they have. So all of these sorts of things we are doing, and I appreciate this is on here, but it does say enable, so we're not there yet, so I won't claim that we are, because there's a bit of a journey still to go on to get that there. Absolutely means we need to improve data quality, and not everybody's on it yet. But it is starting to have an impact. We have really been able to use it to identify a patient that was getting some suboptimal treatment. We've been able to have a further interaction with that patient, change his treatment, and he was back doing the things he wanted to do. He was 93, wasn't able to play golf anymore. We got his medication changed by some reviews of how he was being cared for, and he was back playing golf again. He was on a golf cart. I'll admit he wasn't walking around, but there we go. So there's a little bit of extra information. I think I might have covered that already. One of our GPs loves this. I can't remember who created it now. My head's full of snot. But essentially, we all have loads of data, and having loads of data is great, and it's good for reporting on, but other than that's a bit boring, isn't it? Yes. What we wanted to do is take that data and take it up through that triangle and get the wisdom out of it. And there is value to be had in that. If you can start to change the way your treatment processes work, and earlier on we cut half an hour of something just by looking at changing a dashboard. With all of the data in the same place, and perhaps pulling in demographic data from local authorities, pulling in data from the police, there's all sorts of other things and understandings that we can get out of the data that's out there. And again, we've got a cycle. We keep going around that. We do need to make sure the infrastructure is right, we draw out the intelligence, and then we start to change the way the interventions work. The infrastructure is the key piece. It's the founding stone of everything that's in our digital strategy, because if you haven't got the right infrastructure, none of the cool stuff's going to work. I think, Andy, you had a picture of quite a nice new PC on your screen. Some of the kit that we see is actually probably not much newer than that in some places. And we have to make sure that funding that comes in is put into that grassroots level. Otherwise, there's no point in doing all the exciting stuff on the top. So we do have this architecture in place. We can ingest data now from all sorts of different places. We are using Azure as the hosting platform. We have developed, in conjunction with a university, not one from Dorset, but a university, a de-identification, re-identification process. We were told by the national team to go and use the nationally provided one. I forgot what it's called now. So we went to them and said we want to use it, and they said they weren't ready. So we've carried on using the one we've worked up. And in more recent conversations, they've said actually what you're using is slightly better than what we're proposing to do nationally. So keep using that, until we've got into a position where ours is going to improve. So we have a scalable, robust, available to everybody from everywhere with the right level of authority data set. And it does mean that with all these people providing data in, they can do what, instead of what they were doing in-house, can now be done on this platform. So we don't have, or we won't have, ultimately, 5 or 6 databases around the county, we'll have everybody using one. That does mean that if the council have loaded their data in, they can see just their council data, down to each individual user. They can see anonymised data for every other data set. And a GP can do the same. They can see just their GP provided data and everything else has been anonymised. So they can start in a very small way to compare themselves and to do some basic forms of research. At the minute, this is not aimed at selling data to third-party organisations. This is for our internal use. This is public task, I think, under GDPR, nothing else. So that's what it looks like. That's the main landing page as it currently stands. We've got all sorts of different dashboards already created, and there are more coming all the time. As more organisations start to put their information in, they come with a different ask. And I should add, all of this work is being done by our internal people, because sustainability, which has been mentioned today as well, is another huge thing. We were on the national programme with Optum as one of the early adopters for the work Optum were doing. An earlier quote from Optum said more than £1 million a year to have access to some of the stuff they wanted to do, which would be in a black box, so you wouldn't actually understand how they were processing it. We've got our business intelligence analysts, who are the guys in the back room who just produce spreadsheet reports up until now doing this. So it's much better for them. And it does mean they aren't, because they're not crunching spreadsheets all the time, they can take their knowledge of why the data changes and moves around out to talk to clinicians to say, your data's changed, should we have a look at why that might be? And you start to have that improvement conversation all the time. Histographs, are they? I forgot what those are called. Yeah. It's been really hard to know how many times somebody's come in and to which setting they've had their treatment, for example. So one of the clinicians said, I want one of these. So the guys developed one. And also you can immediately start to see how many times they've been into all the different care settings and for how long and how regularly. And because they can actually add up how much it costs. So you can start to see that one very ill patient might cost £90,000 a year to look after, simply because you've now been able to look at all the different times they've been in for how long and the treatment they've had in each place. So it starts to get really quite powerful, really quite quickly. So we don't have everybody on it yet. We've got 47. Blimey, we've been talking so long we've lost a practice. 47 out of 80 practices, and you can see where the current practices are, who are on. I should add that all bar 2 of our practices now are on the same application. So we've got System 1 installed across the base, which is the same application we're using in Community as well, which does make some aspects of it a little bit easier, I will admit. The final bit then is we've been working with Bournemouth University, which is our local university, on some of their new master's qualifications. We've got some new data science ones there that are focused on health. And we're lining up those people from our teams who are interested in that to get onto those courses to help themselves to develop. But we're also working closely with the university because they've got a lot of PhD students, master's students who are all looking for some work experience and they want to come and try out their cool ideas and then their new ways of thinking. So we want to bring them into the NHS early so we can entice them to stay after they've qualified. And I think one of the things we face is that people don't understand technology. People are scared of technology. We hear that quite a lot, which is one of the barriers of resistance to change that gets thrown up. And lots of the people that will say in those settings that they can't use technology will leave a meeting, go straight onto Facebook or WhatsApp, or they'll be on Now TV on their device looking what they're going to watch on telly, or setting the recorder up with Sky Plus or something. So they all do know how to use technology. It's just a confidence thing, and we have to work on building up people's confidence within that. So as I said, intelligent working is looking to draw data from all of those places. And that's just to start with. Once we've got those, if a clinician comes up with an option saying they want data from somewhere else, we'll have a conversation with the provider and say, can we get that information in, please? And we'll keep going. We're fairly confident that it's a model that's repeatable, and we're quite happy to share how we've moved forward to the point that we have. So if anybody's thinking of doing this, quite happy to have a conversation and help people avoid some of the pitfalls that we went in and the rabbit holes we ran down along our journey. And that's about it. Have we got any questions?
Any questions? Gentlemen at the front, we'll start at the front, work our way back.
So are you? I was just trying to clarify in my head where exactly you're pulling the data from. You're actually pulling data off some of the apps like My COPD, from the My Health, the Dashpad you had up on the board there.
Yeah.
You're getting data from all of those.
So our intention is to get that. At the minute, we're focusing on the in-house clinical systems that we have. By in-house, I mean like System 1,
Right.
GraphNet, so on and so on.
So that's an
As an aspiration
on the apps, but
The other ones, but those are the apps through the innovation stream that we've deployed. So I employed somebody, and I gave them the job title of Innovation Catalyst. So her job is just to go and wreak havoc and bring in new ideas and disrupt people's ways of thinking. And just because of her, most of those apps have come in.
Yeah, hi there, thanks for your talk. So the UK government had a cloud-first policy for identifying information since 2013, and it has digital reinforced that in 2017 as a cloud-first policy. So why are you stuck with a database that probably is GDPR compliant and has privacy shield with using pseudo-anonymized information as opposed to the actual raw name, date of birth, hospital number? Because if you pseudo-anonymize, there's one identifier, there's a risk of putting in the wrong information for that individual.
Mm.
So what's your barrier to using all identifiers?
So it is identifiable to the person that's uploaded it. So if you're uploading it from your acute hospital, you'd be able to see all the data fully identifiable. If I look at your data as a GP, it would be anonymised. So it's a way to protect the data sharing elements of it, and also to stop potentially a commissioner having a look at data to understand why the number of people having a particular treatment has suddenly gone through the roof, because that's a very expensive one. So there's a degree of privacy between organisations still. But we do have a data sharing agreement in place between all the organisations you saw at the beginning and each individual GP practice. So everybody in Dorset is prepared to share their data.
So you're doing all this work. Are you tracking how much money you're saving? Because we've heard at the beginning of the day that the purpose of digital, one of the key objectives, is to release staff time to care.
Yeah.
And you would think release savings. Are you looking at how you're releasing savings?
We're trying to find the best way to track it.
Yeah.
And we, as an example, simple thing like putting in text messaging for GP appointments, for example. We put that in back in 2016, and I think per year in saved, what otherwise would have been missed appointments, we're saving about £1.5 million worth of wasted time. So that's one thing, but obviously it's hard because it's not always cash releasing.
No, but each intervention should be looking at the outcome of what that's saving, whether that's in time, efficiency, actual resources.
Yeah. So waitlist, for example, we took a baseline on ED admissions and MIU visits before we launched it, and the plan is to keep an eye on it, but to seriously have a look at it in about 12 months' time and see how it changed behaviour, perhaps through winter, through some holiday periods. So each one we're having to
each individual intervention, there's lots of them.
Yeah,
okay.
Hi, Heather Thurston from RCST. You talked about proper kit and that being an essential bit, having a proper kit. Was that something that Dorset made an early conscious decision to invest in, or was that one of your pitfalls that you found out along the way? Did you invest in data storage, upgrading your system so that you could manage all this extra data that's going to come?
So the first version of this was running on a server hosted by Dorset Healthcare. We're now getting that into Azure, so that's where it will be finally hosted. The getting the right kit bit really applies to how our workforce are going to interact with it. So we do have some museum piece desktop machines and laptop machines out there, and Windows 10 is forcing the replacement of a lot of those. So it's really, you can put these really good systems in place, but if the network infrastructure, the interaction point for your workforce with the data is bad, then their experience will be bad. So it's getting all that underlying infrastructure working properly.
Does Skype work on a lot of your hospital computers, or is that limited?
It's limited at the minute, mainly because the hospitals haven't all purchased it. So it's the deployment's complete with Office 365 for primary, nearly for primary care. For the CCG, we're just about to start, hopefully, the work for Dorset Healthcare, which is 8,000 nurses. The 3 acute hospitals are still waiting to present their business case, but I'm trying to get some central funding from our system to pay for it.
Okay, thank you.
Thank you very much. Nick?
I was just struck by the answer to the question about the de-identified data, and you said something like, I wrote it down, that it was the fear of the commissioner looking at the data.
Yeah.
Right? Which I think is a really sad indictment on us as an overall system, and it would be exactly the same in Devon, so it's not a Dorset thing. But as you are an ICS as opposed to an STP, and you're the CIO over both providers and commissioners, what difference has that made to this approach, or none at all?
So I think the ICS element helps because, say, we've got that single financial control total in place. So there's no point in hiding that stuff and keeping that stuff hidden anymore. You just get the amount of money you get given. So there's no advantage to producing lots more data. I don't think necessarily my role's been in any way instrumental in helping that, other than setting the challenge for people to go for it in the first place.
Thank you very much, Steve.
Okay.